Let's now talk about rheumatic arthritis. So there are like 200 and like 180 pages still remaining. So let me do it fast. Let me try to do it fast because I know you guys are already very bored by the amount of time I'm taking to complete this topic. So without further ado, let's start the topic now. The clinical features of rheumatoid arthritis. So pain, swelling, morning stiffness in multiple joints, small joints, MIP, so PIP, proximal interfacing joint, MCP and MTP, and spares and DIP joints. That is a very well-known fact. Systems like fever, weight loss, anemia occur. Cervical spine involvement, that is subluxation and cord compression can also occur. So in rheumatic arthritis, cervical spine involvement can also occur. Subluxation and cord compression can also occur. Lab imaging studies. In lab imaging studies, there are positive rheumatic factor and anti-CCP antibodies. Serotonin are correlated with disease activity. So disease activity can be detected by CRP and ESR. Soft tissue swelling can be present. Joint space narrowing, bone erosions are also present. Okay, the patient has symmetric polyarthritis involving MCP and PIP joints with prolonged morning stiffness and associated fatigue is highly suggestive of rheumatoid arthritis. The diagnosis is made clinically by the presence of anti-cyclic citrulinated peptide and CCP antibodies is helpful for confirmation. Okay, tissue inflammation causes arginine residue in the proteins, such as vimentin to be enzymatically converted to citrulline. So when there is inflammation in the tissues, you see how does rheumatic arthritis occurs? So rheumatoid arthritis occur in this way. So there is tissue inflammation in the tissues, which causes arginine residues in proteins such as vimentin. So vimentin is a protein present in, let's say, a cartilage. Vimentin protein has arginine amino acid. So this is enzymatically converted to citrulline by a process called citrullinatation. So this alters the shape of the protein, which can then serve as new antigen that generates an immune response. In RA, the immune response against citrullinated proteins is exaggerated, resulting in high titers of anti-CCP antibodies that are not usually present in other inflammatory conditions. Thus, anti-CCP antibodies have a high specificity for RA. Antibodies to citrullinated peptides or proteins are usually measured by ELISA using a mixture of CCPs and the antigen. So CCPs are used as the antigen, and this is used for detecting RA. So see, there's a vimentin protein with arginine. So this arginine is enzymatically converted to citrulline. So this is called citrullinatation. These citrullinated peptides act as new antigens to the immune system. Thus, anti-CCP antibodies are generated. So now, anti-centromere antibodies are found in major patients with CREST syndrome. So anti-centromere antibodies. So anti-centromere antibodies are also present in one syndrome that I had discussed before, topoisomerase 1, anti-centromerase, and RNA protein. 3 antibodies are present in I forgot. So topoisomerase 1. Anti-centromere topoisomerase antibody is present in us in systemic sclerosis. So systemic sclerosis has these two enzymes, while anti-centromere antibodies are also present in CREST syndrome. So CREST stands for C for, so what is C? C for calcinosis. So C for calcinosis, R for Raynaud's phenomena, E for I have to see esophageal dysmotility, S for esophageal dysmotility, S for sclerodactyly. So sclerodactyly means sclerodactyly occurs, and T for telangiectasias. So T for telangiectasias. So CREST syndrome stands for calcinosis. There is calcinosis, so calcium presence, Raynaud's phenomena, so dysmotility, S for sclerodactyly, and T for telangiectasias. Antibodies to double strand TST and are specific for SLE. Rheumatic factors are autoantibodies targeting FC portion. So what are rheumatic factors? Rheumatic factors are autoantibody that target the FC portion of human IgG that occur in most patients. With RA. So, so there is a human IgG. So there is an immunoglobulin that attacks the antibodies produced against the FC portion of IgG is a rheumatic factor. Their diagnostic utility is limited by the poor specificity, and they're found in approximately 10% of healthy individuals as well, 30% of patients with systemic SLE, and nearly all patients with mixed cryoglobulinemia. So all patients with mixed cryoglobulinemia, healthy patients as well as those with SLE also has a rheumatic factor. So thus it is not very specific. The presence of A and antinuclear antibodies is a non-specific finding of many connective tissue disorders, and antinuclear antibodies characteristically occur in IgM form in patients with RA. So Antinuclear ANA form characteristically occur in IgM form. Normally, an ANA can be formed anti-nuclear antibodies. Antibodies can be generally IgG as well, but in rheumatic arthritis, IgM form of ANA are generally present, but they are less frequent than rheumatic factors. Rheumatic factors are slightly more specific than ANAs, and anti-CCP is most specific for RA. Antiphospholipid antibodies are found in patients with SLE. So antiphospholipid antibodies are found. APLA, APLAs are formed in patients with SLEs, and antiphospholipid antibodies in APLAs. Antiphospholipid antibody syndrome causes hypercoagulability. So there is high phospholipid antibody. So antiphospholipid antibody. So antibody attacks the phospholipids present in the cell membrane. So this causes hypercoagulability, paradoxical partial. So paradoxical increase in APTT. So intrinsic factor deficiency like features are seen, that is APTT prolongation and recurrent miscarriages are very common. Spontaneous abortions are common. So spontaneous abortions are common again. So APTT prolongs and hypercoagulative disorder occurs. Hypercoagulability is present, APTT is increased, and recurrent miscarriages is very common. Now let's talk about osteoporosis. Normal trabecular bone and osteoporotic bone, so this has more gaps. The patient with thoracic compression fracture has multiple risk factor for osteoporosis: Caucasian ethnicity, female sex, post-menopausal status. So if there's a patient with female sex, Caucasian population, and female sex, post-menopausal status, then osteoporosis is very common. There is decreased bone strength, low bone mass, microarchitectural deterioration of bone tissues, presence of fragility factors due to minimal trauma, that is fall from a standing height. So standing height, the fall from a standing life. So there is weakening of bone mass or the degeneration of bone mass, and there are those causing osteoporosis. Early menopausal osteoporosis primarily was cancellous bone. So in the early phase of the post-menopausal status, then cancellous bone osteoporosis is more common, which is very important for maintaining the integrity of vertebral column. Therefore, vertebral fractures are most common manifestations of osteoporosis. With advancing age, the cortical bone, compact bone also, that makes the shaft of the long bones and outer envelopes of all bone becomes more involved, leading to increased risk of hip fracture. And primary osteoporosis, that is not due to underlying medical disorders, serum calcium, phosphorus, PTS, all are very normal. So osteoporosis, there is advancing age, female sex, white, Hispanic, or Asian ethnicity, personal or family history of fractures, potential modifiable, decreased physical activity causes decreased stress in the bone, causing osteoporosis, low body weight, poor calcium or vitamin D intake, alcohol or tobacco use, premature menopause, glucocorticoid use, all of them cause decreased calcium in the body, leading to osteoporosis. Okay. So this is a question on, I think, parathyroid hormone A, B, C, D, and E. So high serum calcium and parathyroid hormone. So high PTS, high serum PTS with low serum calcium. So area A. So in area A means low serum calcium. So calcium is very low and phosphorus is very high. PTS is very high. Is seen in patients with renal failure or vitamin D deficiency. Vitamin D deficiency causes decreased amount of calcium. So decreased calcium means more parathyroid occurs. So decreased vitamin D deficiency or renal failure, where vitamin D cannot be activated. So and similarly B and E. So B and E, there is high amount of calcium and high amount of PTS in the body. B is consistent with hyperparathyroidism. So hyperparathyroidism, so parathyroid is more, calcium is more, and that's it. And high calcium levels with low PTS. So high calcium level is high, but PTS is low. Will be seen in patients with PTS independent hypercalcemia. PTS are appropriately suppressed by high calcium levels. So hypercalcemia is present, but it is not PTS independent. So it is not PTS dependent. So PTS independent hypercalcemia leads to PTS is low, but calcium levels are high. Okay. Which can occur in humoral hypercalcemia of malignancy. So there can be high humoral hypercalcemia of malignancy or vitamin D toxicity. Toxicity causes high increase in calcium, but PTS levels are low. So in patients with hypoparathyroidism, low PTS cause hypercalcemia. So hypoparathyroidism causes low calcium and low PTS. Okay. So joint ligaments. So at review, there is posterior cruciate ligament and medial collateral and anterior cruciate ligament, popliteal tendon, lateral ligament. So this patient has an injury to medial. The patient can have an injury to medial collateral ligament because of lateral, injury. MCL athletes approximately to the medial epicondyle of the femur. MCL. What does MCL attach? It attaches proximally to medial epicondyle of the femur. So it attaches proximally to medial epicondyle of the femur and resists force that push the knee medially. So and resists force that push the knee medially. MCL injury typically occurs in twisting injury or blow to the lateral knee while the foot is planted. So a valgus stress injury. So when the foot is planted, blow to the lateral of the knee causes MCL level tear. So Anterior tear binds to the medial epicondyle up to the tibia. The valgus stress test. Valgus stress test can be done with knee extended by placing one hand along the lateral thigh and pressing down inwards, while the other hand is placed in the medial aspect of the ankle and pushed outward. So laxity of the knee or medial joint line widening indicates MCL injury. The lateral and medial menisci reduce shock and helps transfer force from the upper to the lower leg. Medial meniscal injury occurs kind of a twisting movement of the knee, often accompanies MCL injury. Lateral meniscal injury is less common, but medial meniscal injury is more common because the twisting involved force in the knee. Meniscal injury is diagnosed by joint line tenderness when the knee is flexed. So joint line tenderness can be present when the knee is flexed. So this is how we diagnose meniscus tear. Lateral ligament resists excessive lateral movement of the knee. So as injury is uncommon, but will characterize the knee with variable stress. Anterior ligament ACL resists anterior movement of the medial rotation of the tibia. So medial rotation is prevented, and anterior dislocation, so anterior relocation of the tibia is prevented. Translation of the tibia is presented. So injury is indicated by increased anterior movement of tibia in relation to the femur. Anterior rotates like when this can be done. PCL test of the tibia femur during knee movement. Excessive back movement of tibia is prevented by PCL. So it will occur in injury form. So this is the MRI of knee. This is a patellar ligament. So this is patellar ligament present in the anterior part. So you see the posterior cruciate ligament is present posteriorly, while anterior cruciate ligament is present anteriorly. These are two meniscus, medial meniscus, and this is a lateral meniscus with lateral articular surface, medial articular surface, biceps femoral tendon. So biceps femoral tendon occurs here in the lateral surface. Biceps. The sartorius muscle is present in the medial side. Sartorius muscle present in the medial side. Gracilis tendon, gracilis semitendinous, or the gastrocnemius muscle is present posteriorly. ACL and PCL are found within the anterior capsule of the knee joint and cross one another as they span from femur to the tibia. So they cross each other. ACL and PCL. ACL will start from the lateral side, and that is lateral, all the femoral epicondyle. So lateral side of the femoral condyle. And PCL origins from the anterolateral surface of the medial femoral condyle. So medial femoral condyle, anterolateral surface of the medial femoral condyle, insertion of the posterior intercondyle area of the tibia, the label of tibial plateau, as in the axial at the label of tibial plateau. The ACL is anterior and PCL is posterior. ACL functions to resist anterior displacement of the tibia relative to the femur. PCL presents the posterior displacement of the tibia relative to the femur, and is intercalated by using posterior test. PCL tear most commonly occurs following a direct blow to the anterior proximal tibias during sporting activity or motor vehicle collisions. So anterior cruciate ligament, this is anterior cruciate ligament, and this is posterior cruciate ligament. So a more proximal part side, this dark surface is the ligament, and it runs like this. More oblique is the anterior cruciate ligament, while more vertical is posterior cruciate ligament. Okay, axial CT scan or MRI orientation. So this is axial, patient's right, patient's left. This is a very well-known fact. And posterior cruciate ligament tear occurs here. So this is tibia, back surface of the tibia, posterior intercondyle surface of the tibia, PCL attaches. And okay, so so medial and lateral menisci are crescent bands of cartilaginous tissues that line in the periphery of the knee joint. Meniscus tear associated with twisting of the flexed knee while the corresponding foot is planted. Meniscal damage can be treated by the fetal by joint line tenderness during provocative maneuvers like McMurray test. So McMurray test can be done. So McMurray test can be done by making the patient supine, and then testing for joint line tenderness, and okay, McMurray test is one of the most important tests. They can be rotated medially or laterally, and joint line tenderness can be seen. Patellar ligament, that is, patellar tendon connects the inferior portion of the patella to the tibial tuberosity. So inferior portion of the patella to the tibial tuberosity is connected by patellar ligament. Patellar ligament drops resisted with underlying ligamentous damage. The total disease over its injury unusually occurs following forceful contraction of the quadriceps muscle while the knee is flexed. Contraction of the quadriceps muscle while the knee is flexed, or complete patellar ligament tear would result in swelling and high riding patella and physical examination. Let's talk about septic arthritis. This was a video. Okay, how much video I saw? It is only 4 minutes.
New Kellogg's Muesli. 12 grains, fruits,
Okay, what do you?
It is important to rule out septic arthritis, as this can cause irreversible damage to the joint. Silent symptoms of septic arthritis include fever, monoarthritis, which means one inflamed joint. Inflammation of the joint is characterized by warmth, redness, erythema, pain, and decrease in function or range of movement. The person presenting with an inflamed joint requires a thorough history and examination. For septic arthritis, the main causes of pain, streptococcus, and Neisseria gonorrhea, which is essentially transmitted bacterial. A quick recap.
This is an easy topic now. The patient has acute monoarticular arthritis with an effusion, decreases of motion of the affected joint, and synovial fluid leukocyte count more than 1 lakh. So, synovial fluid leukocyte WBC count is more than 1 lakh, and decreases of motion, and there's more acute monoarticular arthritis with an effusion. So, which are we suspect for septic arthritis. Septic arthritis is very often due to gonococcus in this patient's age group is likely a diagnosis and it should receive antibiotics to given the risk of joint destruction, osteomyelitis, and sepsis. Okay, so synovial fluid chromatine and culture can help confirm the diagnosis. So sometimes cultures can be negative with gonococcus as well. And microscopy can exclude the presence of crystals or suggestive of gout and pseudogout conditions can also cause acute monoarticular arthritis. Gout is associated with alcohol use. The typically present at older age and synovial fluid glucose count is usually lower, so and the 20,000 to 1 lakh per millimeter cube range. Allopurinol is hypoxanthine isomer that lowers serum uric acid level. So it is an hypoxanthine isomer that lowers uric acid level. It is prescribed to prevent attacks of acute gouty arthritis, but is not used for the treatment of acute flares. Okay, so flares are not prevented by allopurinol. Colchicine reduces the flare. So it helps in decreasing the neutrophil migration to the inflamed tissues. Indomethacin can be prescribed in non-infectious, can also be prescribed in gout. Prednisolone is sometimes used in the treatment of gout, where they're contraindicated to colchicine and NSAID. So hydrochlorothiazide, effect of thiazide is on distal tubular calcium reabsorption. See. So see in the thiazide in which sodium chloride channel. So what is the channel? So this is channel, the sodium chloride channel. Sodium is the tubular lumen, and this is the interstitial fluid. So from the tubules where the urine is formed, sodium chloride channel is present in the apical surface of the tubular epithelium. So this is the epithelium. Thiazide inhibit this, so sodium cannot be reabsorbed. So sodium cannot be reabsorbed means so sodium reaction doesn't occur, so sodium follows water and there is diuresis. So there is inhibits it, and there is so sodium less lack of sodium means sodium pump is prevented, so thereby prevented, and sodium pump is inhibited, so sodium stays inside the cell and sodium calcium exchange occurs, and loop loses calcium but thyroid doesn't, so calcium absorption occurs. Calcium absorption occurs because there's more sodium that needs to go out, so while going out calcium comes in. I just told the opposite answer. So sodium, potassium, and calcium, sodium, calcium exchange. So let's see. Thiazide diuretics. So thiazide diuretics, chlorothiazide, chlorothiazide are indicated for the treatment of patients with hypertension, even those who have diabetes mellitus. Although thiazides can cause increased increase in blood glucose, this is very often not clinically significant and substantially after by the blood pressure lowering effects. Okay, then thiazides inhibit the sodium chloride co-transport in the dish of this city, leading to decreased sodium reabsorption. Thiazides can also cause peripheral vasodilation. So peripheral dilation resulting in reduced peripheral vascular resistance. So peripheral vascularization decrease, so it can be used in the case of hypertension. So hypertension has not just increases sodium, decreases sodium reabsorption, but also decreases the peripheral vascular resistance. In addition, thiazide also increases calcium reabsorption in the distal tubule. Studies have shown that the use of thiazide is associated with higher bone mineral density and reduced fracture risk, and many experts recommend them for treatment of hypertension patients with risk of osteoporosis. Increased calcium reabsorption can also cause hypocalciuria, which prevent recurrent renal stones in some patients. Several anti-epileptic drugs like phenytoin, carbamazepine, phenobarbital are associated with decreased bone mineral density. So anti-epileptic drugs induce the cytochrome P450 system in the liver. Therefore, bone mineral density is decreased. Diltiazem is calcium channel blocker. And that can be used for the treatment of hypertension. It also used for rate control in patients with atrial fibrillation. So atrial fibrillation rate control can also be done by diltiazem. No significant level of calcium levels, bone density, fracture risk. Escitalopram is SSRI. Escitalopram SSRI indicated for treatment of depression and general anxiety disorder. SSRI are associated with small decrease in bone density. Their effects on fracture risk have not been studied. So, the calcium or fracture risk of acetylcholine has not been studied. Furosemide loop diuretic used to treat congestive heart failure causes increase in urine calcium loss, causes worsen osteoporosis. Lansoprazole inhibits PPI is a PPI, so calcium environment is calcium or acidic environment is prevented, thus increasing the risk of osteoporosis, decreased calcium absorption, osteoporosis occurs. So metformin suppresses hepatic gluconeogenesis and uh, you know increase insulin sensitivity and peripheral glucose uptake. So peripheral glucose uptake is increased and hepatic gluconeogenesis, insulin sensitivity is increased. It has no effect on osteoporosis risk. Spironolactone is also an inhibitor used to treat congestive heart failure. So spironolactone can cause hyperkalemia, but it does not have significant effects in calcium homeostasis. Okay, spironolactone can cause hyperkalemia. So it can cause hyperkalemia. Potassium sparing, so sparing while sparing potassium, then hyperkalemia can result common fibular nerve. So let's talk about common fibular nerve. Common fibular nerve. These are small topics that needs a very clear understanding of it. So common fibular nerve, just let's just see the photo. So there is a posteriorly running nerve in the femoral area that rounds at the level of tibial head, tibial neck, and fibular neck fracture. So if there is fibular neck fracture, then common fibular nerve can be damaged. Then it divides into superficial fibular nerve and deep fibular nerve. And if common fibular nerve is damaged, then foot drop can occur. Okay, previously called common fibular nerve was previously called common peroneal nerve. So occurs in the level of fibula. Okay, let's see a very small video. Okay, this is a small video. Sorry for the ads, guys. Hello and welcome to Tips. So sciatic nerve branches to communicate nerve and tibial nerve. So posterior in the thigh, thus proximal to the popliteal fossa. So after coursing back around the neck of the fibula, the common nerve divides into superficial deep branches. The superficial part innervates the muscles of the lateral component of the leg. So superficial part innervates the muscle of the lateral component of the leg, which helps in eversion of the foot. And deeper nerve innervates the anterior component of the legs, which muscle acts as dorsiflex of the foot and toes. The dorsiflexion occurs. So superficial perineal nerve provides sensory innervation in the dorsum of the foot. So superficial perineal nerve also provides. So superficial perineal nerve goes to the lateral part of the foot, and controls the eversion and also supplies the dorsal surface of the foot. While the deep perineal nerve helps in dorsiflexion, and deep perineal nerve provides sensory innervation between the first and second days of the foot. So first and second days of the foot can be sensory function is supplied by is contributed by the peroneal nerve. The patient has fracture of the neck of the fibula, so the common peroneal nerve is the most frequently irritated nerve in the leg due to its superficial location as it courses laterally around the neck of the fibula. Injury to the common peroneal nerve from proximal fibular fracture would result in loss of foot sensation, dorsal foot sensation, as well as impaired dorsiflexion and eversion, resulting in foot drop. So here is a fracture of the fibular neck. Okay, so the tibialis posterior, innervated by tibial nerve, is the major muscle involved in foot inversion. So inversion of the foot can be is done by tibialis posterior nerve. Tibialis anterior, tibialis anterior is innervated by common peroneal nerve. The common fibular nerve is less important, and patients with peroneal nerve injuries usually have normal foot inversion. So foot inversion is not affected. So BNE, the tibial nerve courses through the popliteal and innervated skin of the posterior calf. So tibial nerve courses the popliteal and innervated skin of the posterior calf, lateral foot, and sole and tissue of the knee joint and muscles involving plantar flexor and inversion. So all the rest of the muscles are supported by tibial nerve, gastrocnemius and soleus and tibialis posterior. Injury to the tibial nerve cause weakened plantar flexion. So plantar flexion is weakened, so plantar flexion doesn't operate. Inversion of the foot also reduce and distance of the sole of the foot. So, all right. Tibial nerve provides the plantar sole of the foot, supports plantar sole of the foot and causes plantar flexion. But fibular nerve is just the opposite. Less loss sensation of the middle aspect of the foot results from the so medial aspect sensation is results as a result of lesion in the saphenous nerve, the largest pure sensory branch of the femoral nerve. Okay. Intercutaneous nerve of the legs. So there is intercutaneous nerve of the leg. You see, there is lateral cutaneous nerve of thigh. So laterally in the thigh, it's lateral cutaneous nerve of the thigh, and anterior cutaneous branch of the femoral nerve. So and the medial part of the thigh is supplied by middle part of the thigh as well as and leg as well as the foot. So all of them are supplied by anterior cutaneous of the femoral. So femoral nerves, anterior cutaneous branch. So anterior cutaneous branch of the femoral nerve. So in the femur, the femoral nerve branch, anterior cutaneous branch supplies the anterior cutaneous region of the thigh, and infrapatellar branch of the saphenous nerve. So in the around the knee joint, the medially infrapatellar branch. So below the patella, infrapatellar branch of saphenous nerve supplies the middle part, and middle cutaneous nerve of leg, branch of saphenous nerve. Middle cutaneous branch of leg supplies the saphenous nerve. So femoral nerve and saphenous nerve provide the middle part of the legs, while a lateral part is provided by lateral cutaneous nerve of thigh. Peters disease. So I think it was discussed before as well. So the patient with skeletal pain, deformity above the leg, focal warmth has Peters disease of bone osteitis deformans. So it also called osteitis deformans, and is a chronic condition characterized by excessive and disordered bone formation. The affected joint bone becomes weakened, which can lead to bone pain, bowing, fracture, or arthritis of adjacent joints. Increased blood flow in the pediatric lesions can appear as local warmth or bruit and can occasionally lead to high output cardiac failure. So, okay, blood flow in the pediatric lesion. So in the pediatric area, blood flow is more, so bruit can be heard, and it can also cause high output cardiac failure. Okay, patients with Peyer's disease have normal frequently have an elevated serum ALP levels due to the formation of new bones. However, calcium, phosphorus, and pathogenic hormones are normal. In the patient with disease, calcium hormones just remain intact by the disease process. X-rays usually diagnostic, showing mixed lytic sclerotic lesions, thickening of cortical and trabecular bone, and body deformities. So vitamin D was already discussed. So exposure to 7-dehydrocholesterol, provitamin D3 in the skin. So it absorbs UV B rays. This opens the bearing of the 7-dehydrocholesterol. So UV B rays is absorbed, and this opens the bearing of 7-dehydrocholesterol, forming P vitamin D3, which then undergoes thermal isomerization to form vitamin D3 cholecalciferol. This is hydroxylated in the liver to form 25-hydroxy vitamin D, and subsequently to kidneys to 125-dihydroxy vitamin D. Vitamin deficiency leads to osteomalacia with pom-pom pain or tenderness, muscle weakness or cramps, gait abnormalities, and increased fracture risk. Risk factors associated with limited UV exposure and increased risk of vitamin D deficiency with the following. So reduced time outdoors in elderly individuals, patients living in residential care, or who are frequently hospitalized, people who avoid going outside due to high risk of risk of skin cancer, low sun exposure, living at extreme northern and southern latitudes, nocturnal lifestyle, so the shift works or occupation over requiring overnight works, blockade of sunlight, so sunblock creams, and UV penetration, individuals with heavily pigmented skin. The conversion between D to D, D2 to D, and D3 to 25-hydroxy cholecalciferol by 25-hydroxy liver is primarily regulated by feedback inhibition from 25-hydroxy cholecalciferol. So this inhibits, so 25-hydroxy cholecalciferol is of rate limiting step. The conversion to 125-hydroxy cholecalciferol by alpha-1 hydroxylase in the kidney is primarily regulated by PTH. So PTH regulates 125-hydroxy cholecalciferol step, 1 alpha hydroxylase activity, while 25-hydroxylase is self-auto-regulates its formation. So they are not affected in this take place. This does not take place in the skin. 25 hydroxy D 24 hydroxylase. So 20 hydroxy vitamin D 24. 24 hydroxylase converts 24 and 125 active form of vitamin D to inactive 24 hydroxy later metabolites. It is applicable by 25 hydroxy vitamin D to prevent excess vitamin D activity. So the resulting output prevents or counter regulates or inhibits or feedbackly inhibits very loop fashion its pre successive counterparts, and thus functions as counter-regulatory hormone homeostasis enzyme is not affected by sunlight. Okay, let's talk about sarcomere. Maybe it is time we watch a video. Sarcomere. Let's watch a very short video, like that of let's watch this 2-minute video.
Skeletal muscles come in different shapes and sizes, but the main structure of a skeletal muscle cell is basically the same. If we were to take a cross-section of a single muscle, we would find it is covered in a protective sheet or layer called the epithelium. The epithelium protects the muscle from friction against other muscles and bones. It also connects the epithelial muscle to form along with other connective tissues, the tendon, which attaches the muscle together. Each muscle is made of a number of parts, called the secondary. The secondary epithelium is organized to shape the muscle. Each muscle has a line, tendon, and muscle. Almost all muscles are covered with muscles, with one larger but relatively strong, as well as weak springs, such as elbow muscle, with even more muscle lines in each joint. Each muscle layer is made of muscle which are together.
Actin is a fibrous protein attached to the loose bands that are protein plates at each end of the sarcomere. In I bands, they reach the sarcomere that contains only filaments of actin. In A band results from the presence of overlapping filaments of actin and myosin. The H zone represents the presence of only myosin. Let us now examine how a sarcomere undergoes contraction. When a muscle contracts, the actin filaments within the sarcomere slide along the myosin filaments. This has the effect of pulling the Z bands closer together and shortening the sarcomere. This view presents a series of sarcomeres similar to the situation during contraction by a myofibril. Let us now view the molecular detail of the actin and myosin proteins to demonstrate the molecular events that occur during a sarcomere contraction. This scene shows the molecular relationships of actin and myosin relative to the banding patterns of the sarcomere and demonstrates how this relates to sarcomere contraction. Note the relationship of actin and myosin molecules relative to the banding patterns we have discussed for the sarcomere. Myosin filaments consist of cross-links that bind to specific receptor sites of actin. The cross-links between the actin and myosin. Note that the cross-links attach and release independently. If the cross-links acted in unison, they would all be released at once, and the myosin would be detached from the actin, allowing the sarcomere to go back to its relaxed, uncontracted state. Let us look more closely at how the cross-links slide the actin along the myosin. This scene shows the events that activate muscle contraction and the biochemical details of cross-linking and sliding of the actin filaments by the myosin heads. The cycle starts when an electrical impulse from a motor neuron stimulates a muscle fiber. Invertebrate animals may have 1, 2, or 3 motor neurons that control the contraction of a single muscle fiber, and each motor neuron has multiple end plate junctions spread over the fiber surface. The nerve signal from a motor neuron does not generate action potential in an invertebrate muscle fiber, but rather depolarizes the entire surface of the fiber to produce contraction. The electrical depolarization also spreads into tiny membranous invaginations of the fiber membrane called transverse tubules, or T-tubules. The the myofibrils. The T tubules align with the A band in invertebrate muscles. The T tubules essentially carry the electrical signal into the sarcoplasm and along the sarcoplasmic reticulum, a complex of membranous vesicles that serve to store calcium within the muscle. Depolarization of the T tubule membrane activates calcium release channels in the sarcoplasmic reticulum to release stored calcium into the sarcoplasm. To release calcium then initiates the muscle contraction by binding to a protein called troponin. Calcium-activated troponin causes a conformational shift in the protein tropomyosin, which winds around the actin helix and blocks the myosin binding sites on the actin molecule. This frees the actin molecules to bind the myosin head unit. The contraction cycle starts with the myosin head bound to adenosine triphosphate, ATP. The myosin head contains adenosine triphosphatase, an enzyme that splits the high-energy phosphate bond ATP to produce adenosine diphosphate, ADP, and inorganic phosphate. The resulting ADP and inorganic phosphate remain associated with the myosin head, which is also charged with the energy released by the splitting of the high-energy phosphate from the ATP. To start the contraction cycle, the myosin head attaches loosely to actin and releases the inorganic phosphate, which causes tight binding with the actin. After tight binding, proteins in the myosin head undergo a conformational change that results in repositioning the angle of attachment between the myosin head and the actin. The shift in the new conformation pulls the actin along the myosin. After pulling the actin, myosin exchanges ATP for a new molecule of ATP. This results in the release of the myosin head from the actin. The myosin head resumes its relaxed conformation and position, and the cycle is ready to repeat. Let us watch the cycle repeat several times.
Okay, so all right, so this is Z line, Z line. This is also Z line. Same line, and this is and this is okay. So this is Z line. This is Z line, and from the Z line comes this is actin, while this is myosin. This overlapping side and the center part is called S band. This between the actin there is a more light entry which is called I band. The actin forms along with the Z band forms I band, and S band represents the only myosin part, and this is myosin and this is actin. All right. So a sarcomere is composed of overlapping filaments of actin, myosin, and structural and binding protein titin and alpha actinin. So they are overacting myosin as well as titin actinin. So a single sarcomere is defined as the distance between two Z lines. So two Z lines, the distance between here to here is two Z lines. Sorry, yeah. It's called a sarcomere. Okay, a single sarcomere is defined distance between two Z lines. Thin filaments are bound to structural protein of the Z line, and to unbound ends of the actin filament positioned in the middle of the sarcomere, where they interact with thick myosin filaments during muscle contraction. The A bands correspond to the myosin filaments of the A sarcomere. So A bands, the A band connects represents the actin filament, myosin filaments in the sarcomere. In this region, there are myosin fibrils overlap with actin filaments as well as non-overlap myosin filaments. So there is some area which is overlapping with the actin filaments, and there is some area which is not. Okay, the A bands always remain the same length during muscle contraction. The M line lies at the center of the A band. So in the center of the A band, this singular line is the M line, with the myosin filaments anchored to structural elements at the center of the sarcomere. Myosin actin filaments overlap the segment of sarcomere between the S and I band. Okay, then the I band is the region of the sarcomere where the actin does not overlap with the myosin, and the H band is the region where the myosin does not overlap with the actin. So the H band is the region where myosin doesn't overlap with the actin. During muscle contraction, both H and I band decrease in length. Okay, so let's talk about enthesitis. So it's a junction from ligament binding to a bone, nose of a tendon. So it's a sites of mechanical stress, insertion of tendons, ligaments, and joint capsules. So tendons, ligaments, and joint capsules into the bone is called enthes. So, and the inflammation of it is called enthesitis. Common presentation can include Achilles tendinitis. So Achilles tendinitis, posterior heel pain, plantar fasciitis, plantar heel pain, and dactylitis means sausage disease. Ankylosing spondylitis is associated with psoriasis. Ankylosing spondylitis, psoriasis, or reactive arthritis are associated with enthesitis. Okay, the patient has inflammatory back pain. So if there's inflammatory back pain, sacroiliitis might have occurred at onset less than 40 chronic or insidious pain and stiffness that are better with activity and worse with rest. So better with activity and worse with rest. So there is some kind of autoimmune disease at play, which is likely to ankylosing spondylitis. In AS, the inflammatory process is thought to originate in the gut due to an altered intestinal biome. So the inflammatory process is thought to originate in the gut due to an altered intestinal biome. So ankylosing spondylitis occurs because of some altered intestinal biome and defects the mucosal barrier. And the resulting inflammatory response leads to upregulation of cytokines primarily TNF alpha and interleukin 17 occur with ankylosing spondylitis. Okay, with the activation of innate immunity and myeloid immune cells into the skeleton, the resulting skeletal manifestations are most prominent in areas of mechanical stress, primarily at insertions of tendons, ligaments, and joint capsules, connected lenses of the bone. Okay, enthesitis is a relatively specific finding in enthesitis is very specific in case of ankylosing spondylitis and other forms of spondyloarthritis and is characterized by local pain, tenderness, and possible swelling. Common clinical syndrome include Achilles tendinitis, plantar fasciitis, and dactylitis. Achilles tendinitis affects the site of insertion of the Achilles tendon on the cancellus calcaneus and typically in the aspirin in the posterior aspect of the heel. Peripheral arthritis is also common in AS. In these cases, inflammatory processes largely affect the articular cartilage and subchondral bone. Synovial involvement is typically minor. However, pain is typically felt within the ankle, that is tibial and subtalar arthritis rather than posterior of the foot. Okay, injury to the cortical bone of the cancellus or the calcaneus can occur acutely due to high velocity fall or cross injury or chronically due to stress fracture in athletes who run on hard surfaces. Patients with encounter back pain make enthesitis a more likely cause of the heel pain. The retrocalcaneal bursitis causes pain and swelling of the posterior heel near the insertion of the Achilles tendon, and it is usually caused by overuse and often occurs in association with Achilles tendinopathy. However, it is significantly less common than enthesitis as a cause of posterior heel pain in AS. All right, now we'll be talking about rotator cuff muscles.
Rotator cuff muscles of the shoulder. The rotator cuff muscles are a group of muscles that form a musculotaneous cuff, which provide strength, support, and stability to the capsule of the shoulder joint. It consists of four muscles: supraspinatus, infraspinatus, tibial minor, and the subscapular. The four rotator cuff muscles support the anterior, superior, and posterior aspects of the joint, leaving the inferior part of the joint the weakest. Hence, an inferior dislocation of the shoulder joint is most common. Supraspinatus. It originates at the medial two-thirds of the supraspinous fossa of the scapula. It passes beneath the thoracoidal arch and inserts into the upper part of the greater of the pelvis. Its actions are: it initiates the first and second degrees of abduction and helps stabilize the shoulder joint. Nerve supply is by the suprascapular nerve. An important point to note is that it is not called joint muscle power to those muscles.
All right, boys. Now let's talk about rotator cuff muscles. So there are four: supraspinatus, infraspinatus, teres minor, and subscapularis. Origin on the scapula, supraspinatus fossa, infraspinatus fossa, teres minor origins from the lateral border, and subscapularis muscle arise from subscapular fossa. Attachment to the humerus, all three of them attach on the greater tubercle, while sub is attached on the lesser tubercle. Function: supraspinatus helps in less abduction less than 15 degrees, more than is 90 degrees, and infraspinatus helps in external rotation, and teres minor helps in adduction and external rotation, and subscapularis helps in adduction and internal rotation. So subscapularis helps in adduction and internal rotation. So okay, supraspinatus and infraspinatus are supplied by suprascapular nerve, and teres minor is supplied by axillary nerve. Teres minor is supplied by axillary nerve. Upper and lower scapular nerve. So subscapularis is supplied by upper and lower subscapular nerve. Teres minor is supplied by axillary nerve. So axillary nerve. Okay, rub muscle originates from the scapula and the proximal humerus. They stabilize the joint, move the arm and the shoulder. Overuse can lead to a trip of injury, resulting in shoulder pain and possible weakness. The specific symptoms depend on which muscle is involved. Resistance added by the examiner when testing muscle function increases tendon loading, elicits pain. When tendon pathology is present, the patient has brain unresisted external rotation. So external rotation when resistance is produces difficulty. So it means some sort of infraspinatus or teres minor can be defective. So teres minor also helps in external rotation. So while also the major external rotation occurs by infraspinatus. So infraspinatus is the main external rotator, and when the arm is adducted by the side, while teres minor is the main external rotator when the arm is abducted. So during the abduction, teres minor helps, while in the adduction, infraspinatus help. So when the infraspinatus turn, there is compensatory hypertrophy of the teres minor, thereby preserving the strength of external rotation. So when there is injury is torn, then compensatory hypertrophy of the teres occurs. So infraspinatus when torn, hypertrophy of the teres minor occurs. Okay, to help in external rotation. So latissimus dorsi, the broad muscle in the medial lower back, origins from the spinous processus same to L5, iliac crest, thoracolumbar fascia, inferior angle of the scapula and the lower 3 or 4 ribs. It is in the bicetal group, the humerus, and helps in adduction. So helps in adduction. Latissimus dorsi helps in adduction. Okay, and extends and internally rotates the arm. So it helps in internal rotation of the arm, not external. So back muscle trapezius here. Infraspinatus, rhomboid major, latissimus dorsi, teres minor major, and deltoid. So serratus anterior is a fancied muscle in the lateral thorax. So serratus anterior is present in the lateral part of the thorax. It originates from first 8 to 9 ribs and insertion to various sections of the scapula. Responsible for anterolateral and rotational movement of the scapula. Anterolateral and rotational movement of the scapula. When the long thoracic nerve is damaged, the muscle becomes paralyzed, resulting in winged scapula. So winged scapula occurs because of long thoracic nerve damage. Winging of scapula occurs because of long thoracic nerve damage, and helps in rotational movement of the scapula. So boxer muscles is damaged. Okay, we know the scapula pushing against resistance. Okay, buddies, I think yeah, pushing on the resistance, normal scapula, wing on scapula. Yeah, so certicus pulls scapula forward and around the thorax. Normal scapula pulls it again around the thorax, but pushing against resistance, it cannot, pulls the scapula forward. But scapula can be pulled forward because of long thoracic nerve damage, and scapula cannot forward, and there is winging of scapula. So subscapularis origins from the subscapular fossa of the scapula, inserted in the lesser tubercle of the humerus. It adducts and internally rotates the arm. So internal rotation of the arm occurs by subscapularis. Supraspinatus origins from the supraspinatus fossa of the scapula, inserts onto the superior aspect of the great tubercle of the humerus. It abducts the arm. Supraspinatus helps in abducting the arm. Alright, the location itself is very self-sufficient. So now let's talk about giant cell arteritis. Let's discuss about giant cell arteritis. Okay, I think this is smaller, and is it a complete video?
Now let's talk about giant cell arteritis. The name has the answer. Itis, inflammation of the artery. So, as you see here, an emergency. So giant cell arteritis, historically known as temporal arteritis. Why temporal? Because the headache is over the temple or the temporal region. It's a granulomatous, median, or large vessel, vasculitis, itis, inflammation of the vessels, which vessels are median or large inside the vessels. It's one of the artery cells.
It's basically a useless test. Why? It tells me there's something wrong, but I don't know what's wrong. That comes in with headache over the temporal region and maybe some joint palpitations or muscle pain. It's the moment, for example, fluid eye. The order is a very fast test. One, high. And also it's high, the eye said no, like steroids, I say high. All right, I think this now makes sense. So it's a female, gray-haired female with something in the temporal region that may be a sign of temporal giant cell arteritis. So the patient with headache, visual and muscular symptoms, and enlarged temporal artery, elevated ESR has typical features of giant cell arteritis with associated polymyalgia rheumatica. So it is also studied with polymyalgia rheumatica. GCA, giant cell arteritis is the most common systemic vasculitis in persons of Northern European descent, that is Scandinavian descent, and most commonly occurs in patients more than 50 years of age. Although both humoral and cellular immune mechanisms have been implicated in the pathogens of GCA, cell-mediated processes are of primary importance. The inflammatory infiltrated in affected B cells is composed of lymphocytes, predominantly CD4 positive T cells. So lymphocytes are present in the affected vessels. Lymphocytes and cells are present, which are CD4 positive positive T cells, and macrophages are present, frequently containing multinucleated giant cells. Therefore, it is called giant cell arteritis. The production of cytokines, particularly interleukin C6, interleukin 6 appear to closely correlate with the severity of the disease. Monoclonal antibody against interleukin 6. So giant cells. So giant looks like G looks like 6. So 6 interleukin 6. The drug is tocilizumab is effective in treating GCA. So there is infiltrate of lymphocytic and lymphocytes and macrophages. So there is lymphocyte and macrophagic infiltrates narrow blood vessel lumen due to intimal thickening, and macrophage fused to form giant cells. Okay, choice in NB. Antibodies to myeloperoxidase and proteinase 3 are involved. So myeloperoxidase and proteinase 3. So antibodies to myeloperoxidase and proteinase 3 are involved in pathogenesis of ANCA-associated vasculitis, for example, microscopic polyangiitis and granulomatous with polyangiitis. So microscopic polyangiitis are granulomatous with polyangiitis. They are involved. And B cell activation factor BAF is a cytokine belonging to the tumor necrosis factor ligand family. So BAF, B cell to activate a B cell. So the factor that activates a B cell is a cytokine belonging to tumor necrosis factor ligand family. Inadequate levels of BAF will lead to immunodeficiency, whereas excess levels can cause autoimmune disease, for example, SLEs. So SLE can result because of BAF. So inadequate level of BAF. So B cells should be activated for immunity. So if it is activated, then an autoimmune disease activated for more than autoimmune disease can prevail, like SLEs. And if it is less, then immunodeficiency can arise. So BAF is one of the important factors. So matrix metalloproteinases are enzymes capable of degrading various extracellular matrix proteins and processing a number of bioactive molecules. They may be involved in cytokine inactivity, but do not play a direct role in pathogens of GCA. So matrix metalloproteinases are not in the pathogens of GCA. For example, now drug-induced lupus. So let's read about drug-induced lupus. Drug-induced lupus. Okay. So let's do a very small. Yeah. All right. Hey guys, it's Medicals for Channel. Let's once again another video of rheumatology and my rheumatology playlist. Today's topic is anti-histamine antibodies, because we have talked about anti-SSA and anti-SSB for Sjogren's syndrome lupus in the previous video. It's time now for anti-histamine antibodies for Sjogren's lupus. Now let's get started.
antibodies. First thing, what the flip is a histone? If you remember your histology or your molecular biology or whatever, here's your DNA nucleus in every histone, every side, in all papers. Antihistones go to antibodies translation, antibodies against the cell, against your own body. Here's what exactly? Histones such as H1, H2, H2, H3, and H4 proteins, I don't care, associated with drug-induced lupus and clinical sclerosis. As already said, we're talking about 95% of what is called the antihistone. Excellent students. Any patient with a drug eruption, you should check antihistone antibodies to rule out drug-induced lupus. Many doctors miss this point, but it's really, really important. Drug-induced lupus can have Question today: what are the drugs that cause drug-induced lupus?
Okay, so features of drug-induced lupus erythematosus. So, drug-induced lupus erythematosus (DIL) has abrupt onset symptoms. Fever occurs, fatigue occurs, rash and serositis. So similar to SLEs, all the features of SLE occur, and prediction for slow acetylation. So, those who acetylate very slow has higher chance of, inactivation of the drug occurs less. So there is higher concentration of drugs in the body, therefore drug-induced lupus can occur. Anti-histamine antibody can be present, and anti-dsDNA can also be present, but it's rare. Implicated drugs are so PIS. So PIS is such an important. So how do I even describe the importance of this drug? So procainamide, which is an anti-arrhythmic drug. Similarly, hydralazine, anti-hypertensive drug, and isoniazid, anti-tubercular drug. So ISPIS, so P for procainamide, I for isoniazid, S for hydralazine. Minocycline and TNF inhibitors, minocycline and TNF inhibitors are also implicated. So this patient's clinical findings: constitutional symptoms and arthralgias and pleuritic chest pain, antihistone antibodies. So clinical features like arthralgia, pleuritic chest pain, and constitutional symptoms, pleuritic chest pain, and antihistone antibodies, and recent isoniazid use. Some of the diagnosis for drug DILE. Unlike classic lupus, DILE typically lacks the usual cutaneous manifestations like malarash. So malarash is not present and is rarely associated with neurological or renal complications. But in SLE, neurological as well as brain as well as kidneys are also damaged. So clinical improvement is rapid and on discontinuation of the causative agent. Procainamide, hydrolyzed, and isoniazid are metabolized via phase 2 acetylation in the liver. So hepatic expression of N-acetyl transferase. So hepatic expression of N-acetyl transferase is genetically determined, and patients with slow acetylators phenotypes are at greater risk for developing DIL. So slow acetylators have greater risk for developing DIL because hepatic expression of N-acetyl transferase. N-acetyl transfer, acetyl transferase means their acetylation. So acetylation reaction occurs in the liver, but this reaction to be but the acetylation of these drugs is very slow because their acetylation are very slow, are and therefore they are predisposed to metabolism is less. Therefore, more concentration of drugs occur in the blood, and it predisposed to isoniazid-induced peripheral neuropathy due to increased drug concentration in the body. Okay, liver hydrolysis is the phase 1 reaction. So hydrolysis is a phase 1 reaction in which a compound is cleaved by adding water. For example, hydrolysis like esterases or amidase enzymes. Phase 1 metabolism usually precedes phase 2 conjugation mechanism. So phase 2 is usually conjugation, while phase 1 is hydrolysis or oxidation reaction. So liver hydroxylation is the phase 1 oxidation transformation. So oxidation transfer phase 1 is an oxidation transformation catalyzed by the cytochrome P450 monooxygenase system. So cytochrome P450 is the monooxygenase system which is involved in phase 1 reaction. So cytochrome oxidase means oxidation of any substrate or substrate occurs, and addition of hydroxyl group reduces lipid solubility and facilitates excretion. So the liver metabolizes the drugs to make it more water soluble, therefore it adds hydroxyl group in phase 1 reaction. So liver sulfate conjugation is a phase 2 sulfate conjugation. So it's a conjugation. So conjugation is phase 2 metabolic pathway that biotransfers drug into more polar compounds and makes it easier to excrete again. And now certain drugs are hydrolyzed by plasma esterases, which rapidly cleave ester linkases after the drug enters the circulation. So certain drugs are hydrolyzed by plasma esterases, also hydrolyze some drugs which rapidly esterases cleaves ester linkase after the drugs enter the circulation. This rapid inactivation allows for short duration of these medications, many drugs used in anesthesia like succinylcholine, tetracycline, remifentanil are metabolized by plasma hydrolysis. Okay, a few drugs are not metabolized in the body; they are actually in the urine, mostly on chains, and are still pharmacologically active. Now let's talk about cubital fossa. So cubital fossa, superior border lies in is a line between medial and lateral epicondyles. So lateral epicondyles, lateral border is brachioradialis muscle, and medial border is pronator teres muscle. So pronator teres, brachioradialis, and line between medial and lateral epicondyle has a fossa, which is called cubital fossa, uh, containing several arteries and nerves. Okay, so the patient's cubital fossa laceration. So if there is any laceration of the cubital fossa, it can result in median nerve injury. So median nerve also passes through this fossa, leading to impairment of forearm pronation. So now pronator teres is affected, therefore forearm pronation is markedly affected, and proximal interphalangeal joint flexion. So proximal PIP flexion. So proximal interphalangeal joint flexion is also affected because flexor region superficialis, which is supplied by median nerve, is also affected, along with sensory deficit in the median distribution. So sensory deficit in the median distribution also occur, and brachial radial artery is adjacent to the median nerve in the cubital fossa. Injury to the brachial artery was most likely responsible for patient's pain. So brachial artery bleeding also occurs along with median nerve palsy, which restricts pronation motion, and also causes the lack of flexion of PIP joint. Okay, the brachial artery is the continuation of the axillary artery as it extends past the inferior border of the teres major muscle. So brachial artery is actually the continuation of the axillary artery and it enters past the inferior border of the teres. So from the inferior border of the teres major muscle. So teres major muscle from the inferior border. The same axillary artery is named brachial artery. In the upper arm, the brachial artery courses in the medial bicipital group. So in the upper arm, so the brachial artery courses in the median bicipital. So there is a groove which is called the medial bicipital groove between the biceps brachii and triceps brachii muscle. So biceps brachii and triceps brachii has a gap from which a groove passes brachial artery, giving off multiple branches like deep brachial artery and running alongside both the median or ulnar nerves. So proximal to the elbow, median or nerve diverge. So proximal to the elbow, median and ulnar nerve diverge. One of the median nerve accompanies the proximally the median ulnar nerve are distant, but when the median nerve accompanies the brachial artery through the cubital fossa lateral to the medial epicondyle. So brachial artery. Well, the median nerve. So this is the median nerve and brachial artery. So brachial, so median nerve. So brachial artery moves in the direction of median nerve, and when it's cubital fossa lateral to the medial and to the proximal anterior forearm, where the brachial artery splits into radial and ulnar arteries. So brachial artery then splits into proximal anterior forearm. Brachial artery splits into radial and ulnar arteries. In contrast, ulnar travels posterior to the medial epicondyle. So ulnar artery moves posterior to the medial epicondyle. However, in the medial side, in the lateral side of the medial epicondyle runs brachial artery as well as median nerve. So medial nerve is more towards to the median epicondyle, 57% of the hand. So median nerve supplies the in the palmar surface the lateral three fingers and a half, and while the remaining middle part is supplied by ulnar nerve, and the radial nerve supplies the very lateral the lateralmost part of in the palmar surface, while the plantar surface, so ulnar nerve supplies the median part of the hand, while the distal part is supplied by the lateral part is supplied by radial nerve. And in median nerve also supplies the upper 1, 2, and so index finger, middle finger, and one half of the distal half of the of the ring finger in the ventral part. Dorsal part of the hand. All right, arteries of the upper limb. Okay, the interosseous artery runs alongside the anterior interosseous nerve, a branch of the medial nerve that supplies most of the deep volar forearm muscles. So, the anterior interosseous artery runs alongside the anterior interosseous nerve, a branch of medial nerve that supplies most of the deep volar forearm muscles. The anterior interosseous nerve and artery originates in the forearm, distal to the cubital fossa. Entry is AIN and artery, the forearm distal to the cubital fossa. The AIN nerve is from distal to the cubital fossa. Okay, median nerve, brachial nerve, and ulnar nerve. So median nerve comes downwards, runs deep distal to the cubital fossa and forms AIN. So AIN means anterior-interosseous nerve, branch of the median nerve, and AIN goes into the volar compartment of the forearm and supplies the volar muscles. Anterior-interosseous artery is also runs alongside the anterior-interosseous nerve, while the superficial branch of the radial nerve runs in the extensor compartment. Our nerval artery runs in the very medial side of the arm. Okay, the deep brachial artery, the first branch. So deep brachial artery, the first branch of the brachial artery in the upper arm. So deep brachial artery, the first branch of deep brachial artery, the first branch of the brachial artery in the upper arm. It courses posterior to the humerus and is vulnerable to injury when with humeral shaft fracture. So when there is humeral shaft fracture, then deep brachial arteries is very prone to injury. Okay. So axillary, okay, teres measures interborder, not then forms interborder. The teres measure then forms brachial artery. Shortly after originating from the brachial artery, the forearm, the radial artery gives off radial recurrent artery. So shortly after originating from the brachial artery in the forearm, so the radial artery gives off radial recurrent artery, which ascends in proximity to the radial nerve near the lateral epicondyle. So radial artery runs close or near to the lateral epicondyle. Together with radial nerve, the radial artery then accompanies the superficial branch of the radial nerve through the most of the forearm. So radial artery then accompanies the superficial branch of the radial nerve through most of the forearm. The absence of radial nerve deficits and laceration, location, cubital fossa near medial can make injury to these vessels unlikely. So okay, because it is present medially, so radial nerve the injury is very unlikely. Radial artery injury is mostly unlikely. And okay, the same. And so there are so many pages of these questions, right? The ulnar artery origins from the brachial artery in the forearm. So ulnar artery origins from the brachial artery in the forearm, distal to the middle epicondyle. Or the brachial artery in the forearm, distal to the medial epicondyle. It runs along the ulnar nerve through most of the forearm. Okay, I think that this also makes sense now. Okay, buddy. Now, so it's like almost like 100 pages here. So okay, but okay, let's talk about femoral head arteries. Femoral head arteries. So there is in the top head of the femur, in the central part of the head of the femur, acetabular branch obturator artery comes. Okay, and there is medial circumflex femoral artery, lateral circumflex femoral artery, in the basis put of the head of the femur, and there are ascending, transverse, and descending branches of lateral circumference femoral artery. The ascending, descending, and transverse branches of lateral circumflex femoral artery, and the medial circumflex femoral artery goes and surrounds the goes inside into the femoral head in the basal region. Okay, and there are retinacular arteries as well. And yeah, I think that is what we have discussed before. So femoral neck fracture. Femoral neck fracture is marked by upward displacement of the femur. Normal femoral neck. So here is normal femoral neck, while here here displacement of upward displacement of the femur. Femur has displaced upwardly and distortion of cortical contour. So cortical contour has also been disturbed. So this distortion of cortical contour has also occurred, which is a marked sign of femoral neck fracture. The patient's X-ray shows femoral neck fracture. So femoral neck fracture. So let's see a video on femoral neck fracture. Femoral neck fracture. Okay, here's just a 2-minute video.
Femoral neck fracture anatomy. Just naturally, it is possible to test like about the forms that can obstruct when the inferior part of the femoral neck and end of the neck is only often
There's no periosteum in the femoral neck and no abundant callus. So there's no callus in the femoral neck, and the periosteum of the femoral neck is also absent. The fracture heals by
The median femoral circumference artery is the most important blood supply to the femoral shin. In young patients, the injury is usually high energy than medium and less common causes. Some medium injury can be less than
There's right-sided femoral neck fracture, which is common in elderly patients with osteoporosis or fallen. So, fallen osteoporotic females generally can have femoral neck fracture. Femoral neck fracture, especially when displaced, put the femoral head at risk for osteonecrosis if the blood supply, avascular necrosis of the femoral head when its blood supply disrupted. The blood supply to the femoral head derives mainly from the ascending cervical and retinal branches of the medial circumflex femoral artery. So, medial circumflex femoral artery is one of the crucial sources of blood to the femoral neck, and the ascending cervical and reticular branches from the medial circumflex femoral artery is most responsible for its blood supply. These vessels are especially vulnerable to damage from fractures of the femoral neck due to their close association with it. The deep femoral artery gives rise to the medial and lateral circumflex femoral arteries. So deep femoral artery gives rise to median and lateral circumflex femoral arteries. However, the injury to the deep femoral artery is less likely because it's remote from the femoral neck. Branches from of the lateral circumflex femoral artery and femoral and superior and inferior gluteal arteries join. So branches from lateral circumflex femoral and superior and inferior gluteal arteries join with the medial circumflex femoral artery to form trochanteric anastomosis. However, these arteries can provide minor contribution to the blood supply of the femoral head and neck. The obturator artery gives rise to the right artery of the recommended teres, will supply a minor portion of the femoral head. This vessel is important in children because it supplies the region of the femoral head proximal to the epiphyseal growth plates, so varies of limited value in adults. Okay, we'll begin in the next video. Till then, bye bye.